when the patients are alive. And for those who relapse, that is primary metastatic disease, relapse and refractory disease, there is least amount of uh, systemic therapies which you can give to these patients and improve the survival of these patients. And there are many barriers now. The barriers are, you have treatments which you are extrapolating, you're treating the adult patient with some treatments, and since you don't have trials of those in the pediatric population, you're just extrapolating those results on the pediatric population, which is very difficult. The reason being, again, the tumors, solid tumors in pediatric patients, there's a lot of heterogeneity. They're unique in their type, they're unique in the molecular characteristics, they're unique in the pathogenesis, and they're unique in the outcome which they show, or the responses they show to similar therapies which have been used in adult patients. So now, I hope majority of you know what NGS is. So it's a next generation sequencing. So this has helped us to come up with next generation of therapies, because this can find out that what targets are there which can be hit specifically in the solid pediatric malignancies, which can be targeted, which can give you more benefit, better survival, better PFS, and the least side effect to these patients. So you have a, what do you call it, precision guided operation, precision decide, it's PGT, sorry. It's pediatric, it's precision guided therapy for these patients, and for that you need an NGS. You do have an IHC panel for finding out these targets on the solid malignancies. You can use DNA and RNA techniques also, but NGS is one technique in which you can find out the target which are already known, and you can come up and know with lot of pathogenic molecular and genetic mutations which are naive to these cancers, but you do have a druggable targeted mutations which can be used and treated for these patients. So there has been a large retrospective study in which they saw that there were around 65% of the patients who did show the targets, but the use of the targeted therapy was just limited to 10 to 35%. Reason being, the extrapolation of the results on the adult studies, and they were explorated for the pediatric population. So the clinicians, the pediatric oncologists, the pediatricians, and the surgeons, which form a cohesive team of pediatric oncology, there were a lot of reservations about whether they were going to show the same results what they show in adults or not. Sorry. Not working. So because of this, they were not very clear, this precision guided therapy will work the same way as adults. So there is, the acceptability is very meager. And what we can do is, you need to collaborate, the pediatrician, primary pediatrician, the pediatric oncologist, the pathologist, the caregivers of the survivor clinic, and the caregivers. They need to come out together and do some collaborative research, including the pediatric nursing oncology people. You can get together and decide for that what you can get for these patients in the best form with least toxicities. So this was the summary of the precision pediatric oncology decisions. If you see here, there are around 32 to 65% of the patients who had some targets in the solid malignancies when they underwent a genomic profiling. It was in the form of whole exome sequencing, it was whole genomic sequencing. So up to 65% of the patients were showing the targets, but you look at the patients who actually received these targeted therapies. It varied from 13% to 19% only. So acceptability has to be there, and that acceptability will come with evidence. So coming to the next generation therapy, so this is the whole rationale and premise of why you need a next generation of treatment, because of the dismal results in advanced diseases and poor prognosis in patients who are relapsed refractory and with limited options once you're done with the first line of chemotherapy. And there's limited chemotherapy drugs, the conventional chemotherapy drugs which you have for these patients. So I will covering the next generation therapies, I will covering, it's complicated. Again, it needs a whole day to debate on, not a whole day. I think one topic can be covered in just a day. But I'll try to give you a holistic picture of what exactly each of this next generation therapy means and where it holds its ground now and what is the future for these. So the next generation therapy, the first I'll talk about the molecular targeted therapies, the second will be immunotherapy, the third the CAR T-cell therapy, which is coming up in a big way, and it's changing the way we used to manage relapse and refractory diseases in the adults and in the pediatric population, the hematological malignancies. I'll come to that also. Then you have gene therapy, it's still in infancy, but whatever disease is being treated with and what results we have from the phase 1 and phase 2 trial, they're absolutely stunning and amazing. And the third and the last is the combination of one or each of these 4 types of next generation therapies we have. So what do you mean by these molecular targeted therapies? Like I said, precision medicine that blocks specific molecules which are involved in tumor growth. And how you get these molecules? You can get it by doing a biopsy. You do a IHC, you can do a DNA based test, you can do a RNA based test, and the best if you want to find out many new targets, molecular targets or genetic mutations, then you go for the next generation sequencing in these patients. The rationale is why you want to target the molecules because of which the tumor cell is growing. Why? The rationale is very strong. You want higher specificity, you want fewer side effects than what was seen with the traditional chemotherapy drugs. And examples for these are like there are a lot of monoclonal antibodies I'll come with, and there's small molecules which are used, which are oral therapies, and they've been used very successfully in the adults, but in the pediatric population they're still in the phase 1 and phase 2 clinical trials. So on the left side of the diagram you can see the EGFR, it's a molecular target on which you have druggable medications for that. You have ALK, that is anaplastic lymphoma kinase, it's again a second target.
Hello.
Which you have IGFR,
Hello,
1R, the time is there? Okay.
Yeah, please.
So you have, then I think I need to hurry up. So these are the targets which you can use specific drugs for. So this is the table in which you see you have ALK mutations on relapse and refractory neuroblastoma, and patient had a 2-year survival of right from 78%, 75%, which was unthinkable and unseen before, and majority of these patients were relapsed and refractory. So now you have BRAF mutations, you have histone modifications, you have ALK fusions, you have PDGFRA mutations, and all these can be targeted with drugs which are available. And if you see, the overall responses went by more than 40% to 60%, and the overall response rate varied from 50% to 90%, which was unthinkable and unseen before. So the advantage again, it's a precision treatment, lesser side effect, better outcomes, better response rate, and better progression-free survival. But still, phase 1, phase 2, you need to have randomized control trial for these. Now coming on to immunotherapy, the definition is there are drugs which use the body's immune system to control the cancers inside the body. They're known as checkpoint inhibitors, and the common example are nivolumab and ipilimumab. They act on PD-1 and PD-L1 and CTLA-4 receptors, and they help you to control the cancer cells by using the own T cells of the body. So there have been trials on this, and if you see the response rates, they vary from 35% to 60% in patients who had relapsed and refractory disease, which was less than 5 to 10% with the conventional therapies. So game changer. So coming on to CAR T-cell therapy, it's the latest form of treatment. It has changed the way we have been treating relapsed, refractory and metastatic diseases in the hematological malignancies, in solid malignancies, especially in the adults. And in hematological malignancy, if you see the B-cell lymphomas, leukemias, which are relapsed and refractory, which had no subsequent treatment, if you treat this patient with CAR T-cell therapy, there is a response rate of approximately 90%, with complete responses of around 50 to 60%. So it is totally, there is a paradigm shift in the management of these B-cell leukemias, and similarly things are changing for solid pediatric malignancies also. And what is CAR T cell? You take out the T cells from patients' blood through apheresis machine. You genetically engineer them outside in vitro. You put a synthetic antigen, that is CAR, chimeric antigen receptor. Then you again grow them outside, multiply them to the tune of 10 to 8 into 10 to the power of 8. You reinfuse it back inside the patient, and these cells will specifically target those cancer cells which have that antigen for which they have been genetically engineered outside, and they're very specific in targeting those cells, and that is the reason why you have amazing response rates, and you have patients who have a complete response rate in pediatric solid tumors ranging from 20 to 35%, which was not seen before. The limitation is that you see a cytokine release syndrome, which is reducing with, you had a CAR T cell therapy, first generation, second, third, or fourth, and fifth, and now the latest fourth and the fifth generation, they take care of the CRS also because they're very modified, and they do not take into consideration that they act on the normal human cells also. So, yeah.
Presenting an interesting topic.
Yeah, I know.
Very short of time we have to wind up.
Fine. So I've done with this also. So gene therapy is also there. The commonest is the CRISPR is like you can edit the DNA of the cancer cells. You can add, you can delete specific DNA sequences. You can modify them, and this is how you can improve the patient's outcome. And you have seen a complete response of 8% in patients who were totally relapsed and refractory, had no treatment, but this treatment is coming up in big way to give respite to these cancer patients. So there is combination of drugs also. Again, you can mix one targeted therapy with CAR T cell, you can mix one targeted therapy with the immunotherapy, and the results are amazing again. So conclusion is, precision medicine is the treatment option for this relapsed, refractory, and metastatic disease. Innovative therapies like gene therapy and CAR T cell therapies are coming up in big way. This is the future of oncology for systemic therapies. Combination of therapies is definitely required because one drug leads to resistance, multiple drugs prevent resistance, delayed resistance. You reduce the long-term toxicities, and you have excellent complete control rates, overall response, a better progression-free survival with good quality of life, with least side effects, short-term as well as long-term. Thank you. Sorry for overshooting the time.
Thank you, Dr. Shah. I think we'll take the questions over lunch. We can continue with the next session.
Sure. Thank you.
Thank you very much.
Thank you for sharing your expertise, sir. And I would like to share my sincere gratitude to all the chairpersons to facilitate the session smoothly. And now we would like to felicitate our speakers. So I request Dr. Abhinav Chaudhary to kindly come on stage, please. I request Dr. Prabodh Goyal to kindly felicitate Dr. Chaudhary. A round of applause, please. I request Professor Dr. Shabab Lalit Angurana, sir, to kindly come on stage. I request Dr. Manish Pathak and Dr. Anand Pandey to felicitate, sir. Thank you, sir. And now I would request Professor Dr. Nasir Ahmad Bhatt, sir, to kindly come on stage and felicitate our chairpersons. Thank you, sir. Dr. Prabodh Goyal, sir. Dr. Manish Pathak. Dr. Anand Pandey. Thank you, sir. Thank you all. So, with this exciting and insightful sessions, we would now move forward to a mini tea break, and I think we'll begin our session after 10 minutes. Thank you very much for patient listening.
ਸੈੱਲ ਵੀ ਲਾਈ ਗਏ ਆਖੀ ਨਾ ਜਦ ਮੈਂ ਚਾਹ ਪਕੌੜਾ ਖਾਈ ਜਾ ਮੈਂ ਬੈਠਾ ਇੱਥੇ ਜਾ ਖਾਈ ਜਾ
7 तारीख की डेट को सामने पे है ये डेस्कटॉप ऊपर है 7 तारीख की डेट हाँ जी सर हेलो हेलो सर विंडो से पी वाला बटन दबाइए डुप्लीकेट कर लो सर विंडो से पी वाला बटन दो विंडो से पी वाला दबाइए तो वो करना डुप्लीकेट
नहीं अभी वो अभी सर का नहीं है
ठीक है वो आ गई है हाँ वो आ गई है एक मिनट से मैं दोबारा कर लूँ कोई कर लूँ
मैम इसमें लास्ट सेशन की सारी पीपीटी आपके पास है
सारी बाकी उनके पास है 4 मेरे पास है 4 मेरे पास है कुछ भेजी हुई है सर ने आपको
सेशन 2 आया वो सेशन 2 नहीं सर
हाँ इसमें है सेशन 2 कॉपी करो सर
में बारिश आ गया
नहीं है इसमें
कुछ नहीं है
खाली है
इसको पता क्या करना फॉरवर्ड करके फिर डालना
नहीं मैं कुछ
न्यू फोल्डर देखिए हाँ ये सर
क्या लिखिए
ये है सेक्शन 2 है पोस्ट लंच
सेशन 2
हाँ बस ऐसा नंबर कर दो ऐसे मत करो
नहीं वायरस ये पहले भी पहन रही थी ना इन्होंने डार्विन सर की उसमें वायरस था मेल करते हैं मुझे
मैं अपने लैपटॉप में लगा के देखूँ
हाँ नहीं चेक करो हाँ मुझे मेल कर दो
ये कर देती हूँ
जम्मू यूनिवर्सिटी डॉट
लगेगी नहीं है मैं कनेक्ट कर लेती हूँ
सर ने अपना मैम देते हैं
विपिन भाई पेन ड्राइव में जो है पेन ड्राइव चुका रही थी हाँ वो आइए डार्विन सर का तो आइए लगी ये 7 तारीख नंबर ही आपकी लास्ट डॉक्टर बना देखो आया नहीं हाँ नहीं सेशन 1 नहीं जाना थले ही है हाँ ओके अभी है नहीं बैक करो 7 तारीख की डेट खोली थे थले रघुनाथ यादव ने चले डॉक्टर लक्ष्मी मुझे चले ना बैक करो 7 तारीख का फोटो चलो सीधा हाँ थले रबे सब थले हाँ एक लिखा हाँ यो तो है डॉक्टर डालना सीधा वो नहीं है इनकी फाइनल आई है हाँ आहो आहो कर लो जो लिखी ना ये नहीं है डॉक्टर डालना नहीं बस ये बात ठीक है डिलीट नहीं करो नहीं इस बार वाला चलाओ बाहर चला लो डिलीट नहीं करो बाहर वापस चला लो पता नहीं चला नाम देखो शो नहीं कर
आपकी इसमें वायरस तो नहीं है
नहीं मैं वही लगाया एक सारी डॉक्टर सर का ही लगाया है पेन ड्राइव तभी तो पेन ड्राइव कहते हैं यू अवॉइड करो मैं मेल ही कर रहा हूँ
हाँ
Good afternoon all and welcome back after the break. Now we are starting with another session. To begin with, may I first call upon the respected chairperson for the session. First, I will call upon Professor Dr. Anita Vick. Ma'am, please come on the stage. Ma'am is a professor and head Department of Anesthesia, GMC Jammu.
सर सेशन 2 में कुछ नहीं है
मैं आपको ईमेल से सेंड कर देती हूँ.
Now I call upon Dr. Shruti Sharma ma'am. Ma'am is additional professor, Department of Anesthesia, AIMS Jammu. Next I call upon Dr. Sheetal Ganjma. Ma'am is assistant professor in Department of Pediatrics, AIMS Jammu. May I call upon the speaker of the session, Dr. Tracheobronchial ma'am. Ma'am is the associate professor in Department of Anesthesia, AIMS Jammu.
वो लास्ट में बैंडेज लगाई ना डॉक्टर रानी से टीचर उसमें वाले सर हमें को मेल करवा
मेरी बैंडेज इसलिए खराब हुई है. ये एक ही चाहिए उसको.
A very warm good morning to everyone, respected chairperson, my seniors of the dais, my colleagues, friends and students I can see. A very good morning. So the topic I'm going to cover today is on pediatric airway management. So it was thought that airway is only the domain of anesthetists. But I think not even surgeons, everyone, even the nursing staff, even the technicians, they should know how to deal with the airway and how to secure a airway in case of emergency. So since my topic is pediatric airway, I would like to let all know that pediatric airway is not different. It's not difficult. It's just different from the adult one. And children, they are not small adults. So it's not that the glottis is miniature form of the vocal cords, the miniature form, their lungs are miniature form of that of adults. So coming to few basic differences of adult and pediatric airway. The head in the infants, it's large, has prominent occiput, and in adults it's flat occiput. Tongue is relatively large in infants, and it is relatively small as compared to infants and adults, as comparative to the size of the oral cavity I'm talking. Larynx, it is kept in position, and it is higherly placed in the children as compared to adults. Epiglottis is floppy, omega shaped and very soft in children, and it is opposite to C4 and C6 in adults. Vocal cords, they are short and concave, and the smallest diameter in infant is the cricoid ring below the vocal cord. Now, I want you all to extend your head and sniff the morning air. Yeah, thank you. Why I'm telling you, because there are 3 axes in the airway involved: oral axis, pharyngeal axis and laryngeal axis. And mind it, they are not in the same line. So whenever we negotiate laryngoscope, they are not in the line, we will not have a good view of vocal cords. So you can see in this CT scan picture, the neutral position, when your head is in neutral position, the primary curve, they have concavity and convexity. So line is not straight. So when we do sniffing position, which I told you to do, sniff the morning air, this line aligns. So when we do laryngoscopy, there is slightly straighter path for the tube negotiation. So because again I'm talking about the large head and prominent occiput. So to put these patients in sniffing air position, we have just to extend the neck and chin up, or we can use props also if we are facing difficulty to make a sniffing air position. So we can use a shoulder roll or a headrest. Coming to the anatomy of the airway, as I told that the airway is conical in pediatric patient, and the narrowest portion is the cricoid ring. So what is the importance? If the cricoid ring is the narrowest portion, so your tube may pass through the vocal cords, but it may not negotiate towards the cricoid ring part, because it's a closed ring. So for that, we have to select the appropriate size tube. So usually for sake of convenience, you can remember that preterm neonates 2 to 2.5 size MMID tube will negotiate. For all term neonates, remember size 3, not more than that. Till 6 months 3.5 and 6 to 1 year 4 mmI. There are complicated formulas too, but for the sake of remembrance, you all can remember that the size of pinky finger corresponds to the lumen of the endotracheal tube. So commercially available smallest size tube is 2 mmID, but in one case which we published, there was a subglottic stenosis in a neonate where even 2 size tube did not negotiate it. So we used 6 French feeding tube with endotracheal tube connector and gotten this tracheophageal fistula case nicely. So coming to tongue, as the tongue is large in proportion to the oral cavity than in adults, and epiglottis is U-shaped and floppy. So what is important to choose a correct type of laryngoscope blade. So we have 2 commercially available blades, Macintosh, which is curved blade, and the Miller, which is straight blade. So what we prefer is the Miller blade for the pediatric patients, because the tip of the Miller blade, it helps to lift the epiglottis and it occupies less space in the oral cavity. So the path is clear and there is more space to visualize the vocal cords. So there is, because as I told that the glottis is higher placed in the pediatric patient. So you have to align the vocal cords. So there is a burp maneuver which is backward, upward and rightward pressure to bring the vocal cords into the view. So you can do to troubleshoot if you are not visualizing the vocal cords properly. So these are the equipments required for the intubation. Before attempting any intubation or for any emergency scenario, you should have an intubation card ready which should contain all the types of laryngoscope blades, all sizes of blades, LMS, all sizes of endotracheal tube, tapes to secure and all the masks. So I would like to emphasize on pre-oxygenation part. Even in ward, if you are going to intubate, see, intubation is not a success, but oxygenation is a success. So in any case, you have to oxygenate the patient. You don't have to let hypoxia happen to the patient. So pre-oxygenation, one, it allows a safety buffer during the period of hypoventilation and apnea, and it extends the safe apnea time. So in ward, you can use your ambu bag with the oxygen source connected. Now, how to hold the anesthesia face mask? It is very important because we straight away jump to the intubation part. But since the oxygenation is important, so you have to choose the right side of a mask. You have to position the child. You have to create a tight seal, ventilate, and avoid gastric distension, and preferably use clear mask in the pediatric patients. Now, there is a C and E technique which I want to tell you. C we make with our thumb and index finger, which holds the mask in upper part. And E we make with all the other 3 fingers, which are placed on the bony part of the mandible. You don't have to compress the soft tissue of the kid because it will result in further airway obstruction. So C will pressure down and E will press up. So here is a short video which I am dictating for how to hold a mask properly. So remember this C and E technique. So if there is obstruction, you have to use oral airway during the mask ventilation. So sometimes when the patient is getting dipped, saturation is getting dipped, most probably his tongue is falling on the back side of the pharynx. So what happens? There is trouble breathing. So you can see this patient is having trouble breathing. So you have to choose the appropriate size of the oral airway, which we can see with the angle of the mouth and the tragus. The appropriate length you have to choose and insert the oral airway. And after that, the child settled and we were able to ventilate normally. Now, how to intubate? For intubation, the basic steps are the proper positioning of the patient, which I told earlier. You have to choose the correct size of the laryngoscope blade. You have to choose the perfect size of the endotracheal tube. How to know? Like, you have to properly hold the laryngoscope and properly insert it. You have to have the knowledge of the landmarks where you are going to put tube, how vocal cord looks, how esophageal opening looks. So all this knowledge there should be there. So for preterm, we usually use 00 or 0 size Miller blade. For neonate, 0 to 1. An infant, 1 size Miller blade will suffice. For toddlers, we can use 2 size Macintosh, and from 3 to 5 years, we can use 2 to 3 size Macintosh. So shaping of endotracheal tube is also important. Sometimes the curve is very flat, so we can fold the tip a bit to let it negotiate through the vocal cords. So first step is gentle neck extension. Then hold the laryngoscope in left hand. Then insert it through the right angle of the and take the tongue towards the left. I know with pictures it's difficult to demonstrate. I have kept a video for you. This is a neonate being intubated. So neck extension, opening of mouth, insertion through right side, shifting the tongue towards the left side. Now he is doing a maneuver just like a bird with his middle finger to visual. So now he has asked for the help to give a maneuver. And you have to make a space at the angle of the mouth and negotiate the tip. So you have intubated now. So where to fix the tube? So the simple hack, there is very complicated formula also available, but simple hack is tube size into 3. So if you are using 3 size endotracheal tube, multiply it by 3 and you have to fix it at 9. So usually the neonates in which we are using 3 size endotracheal tube, we fix it at 9 and preterm may be below that. Now what if you are not able to intubate? What you will do in ward? So please try to mask ventilate and oxygenate the patient. You can take help of the video laryngoscope or insert an LMA for the rescue ventilation and oxygenation. So I advise that all the surgical wards, medical wards, they should have LMA, especially iGel, which is a preformed LMA for the rescue ventilation and oxygenation. So a simple video for the sake of showing video laryngoscopy. See, sometimes neck extension is not required for the video laryngoscopy, but adequate mouth opening should be there. And then we have to visualize the epiglottis. Further go and you can see the vocal cords. And under the visualization, we can negotiate our endotracheal. So some sorts of manipulation and training is also required during the use of video laryngoscopy. It's not that you have video laryngoscope in your ward and you will be able to intubate. Any new equipment still require a training. Sorry for interruption. I think I'll get more time to complete my talk. Okay, so what if you are not able to ventilate? You tried mask ventilating, but mask ventilation is not working. Now, other thing is which you can do is to insert an LMA and ventilate the patient and oxygenate. So, for LMA insertion, I again have kept a video. So, there are many commercially available LMA. I am showing LMA iGel, which is thermoelastic, made up of thermoplastic material. It is having preformed curvature and drain tube also come with, except in size 1. It comes from size 1 onwards. So pediatric patients who are under 5 kg can be ventilated with LMA size 1. A gentle neck extension, mouth opening. You have to lubricate the LMA on the top side and just simply slide it along the palate and you are good to go to ventilate the patient. So fixation, usually we do maximal to maxilla and mandible to mandible fixation to properly secure the allergy. So I would emphasize on role of training for every equipment we use. I recommend all the surgeons and other people to attend the airway management workshops. Train on simulators. You should know your equipment. I recommend keeping video laryngoscopes in the ward as they are very helpful, but still training is required. So what I can suggest, there are many airway workshops done all over the India, but exclusive pediatric airway workshop, it happens every year from on March or April in New Delhi, and it is organized by the Indian Association of Pediatric Anesthesia Delhi branch. So any other questions you can ask me. I'm over with my talk. Thank you.
Very nice talk, Dr. Raksha. Enlightening, very nice. Just to add a few more points, I would just like to say that since the anatomy of the pediatric patients is different, there's a role of para-oxygenation in pediatric patients. Like you can start with a nasal cannula, you can put a nasal cannula and you can give para-oxygenation to the patient. That will decrease the hypoxic period. There will be no hypoxia. That will be another safety factor for that. And one more point that since we are dealing with pediatric patients, many of them will have loose tooth because they're in that age group. So it's very important that we should check the dentation of the patient before and after. Like patient might be having loose teeth, and during manipulation you can lose a tooth and it can become firm. So that is very important. And one more thing that while putting in the oral airway, we can put it straight in pediatric patients. There's no need to give a 180-degree rotation because that might cause some injury to the posterior pharyngeal wall and it can bleed. And another thing is that as far as the video laryngoscopes are concerned, gyroscope is very good because that gives a very good alignment for the airway. Very nice talk.
Thank you so much.
Dr. Raksha, thank you very much for this elaborate talk, very nice. And there are certain things which I just wanted to add that in a proper operation theatre where all the things are set, but talking about the non-operating room. So just like I wanted to ask you, like, what all preparation for the airway management, seeing our Indian scenario where we probably don't have MRI suits in every area of our hospital. So what precaution or what care additional you would want to take for a non-operating room anesthesia or in vis-a-vis airway management is concerned?
So Dr. Shruti is talking about non-operating room side where we have to anesthetize the patient. Okay, so we need to have the proper setup. Like if there is MRI suit, then you need to have an MRI machine, compatible anesthesia workstation, then all the equipment trolleys which are compatible to the MRI suit. So all the equipments which are without some metallic component, like IGL I was mentioning, it is a beautiful device. So it don't have any metallic component in, so it can be kept as a rescue airway for the MRI suits. And you need to have a backup support also outside the MRI suit, because sometimes it happens things don't work while the patient is in MRI. So the support system should be in place. So that's what I can say. And in the ward you were talking
Absolutely, you're absolutely right. And LMA is one of the options. And before that, we can very well have nasal cannulas for oxygenation and equipments. Seeing the Indian scenario, we can have the basic monitoring if we can have. And
we should have all the multi-para basic monitoring.
Yes.
Because in OTs we have a lot of people's help around us, but in NORA we can have just one technician or one person will be with us. So it's very, very mandatory to check the difficult airway cart before we
that's
start.
What I was asking about support system. We have to have a strong support system.
And looking at the drugs drugs also. We need to have drugs which are shorter acting, which will not be giving a very prolonged sedative effect to the patients. So we need to titrate our drugs accordingly. Thank you.
Thank you for the excellent talk, ma'am. Ma'am, in 10 years, I have encountered 2 neonates with congenital high airway obstruction. And in both the cases, we could not intubate with the smallest ET tube available, even with the feeding tube, we could not pass it. And both these neonates, they succumbed within hours of birth. And what should we do next?
So you could have placed a IGL LMA size 1, which is compatible for neonates.
That we did, but still there was no ventilation happening properly.
So could you see the glottis for them?
Yes, we could see the glottis,
And
but
your smallest size 2 did not pass?
did not pass. We tried with the feeding tube, like you did, you mentioned, but again we could not ventilate that child.
Okay, if in that case, were you able to mass ventilate the patient? Dr. Darwin wants to do tracheostomy, I guess.
Actually, in Western setup, these patients are diagnosed antenatally, but here we get them diagnosed postnatally.
Answer for that, Dr. Archana is here during our training course. We had a newborn baby for diagnosis, and we had to immediately.
So there are many options. Dilatation of the subglottic stenosis is also possible. Yeah, then tracheostomy is the only last option, I guess.
Said that thank you very much for this very nice talk, and it's really important for all of us actually.
Yes.
That irrespective of your specialty, in fact, the surgeon should be always posting for initially for 3 months, then 3 months. So all those basic things they will teach us. I mean, in fact, understood. Always in our own ICU because such a something they were struggling with this intubation. So we would intubate them and that workshop at Sher Kashmir, because now we put for our PGs. I think intake capacity around is every year we have 30 PGs, so it makes around 100 PGs in the total. And a good number of PGs are from the Jammu region, around 60%.
The capability of skins I train from
usually
skins.
Usually the females come there, so every year they have this, shot there. So,
Thank you, sir, for your comments, sir. So Dr. Darwin can answer that, like how comfortable the ENT surgeons are for doing neonatal tracheostomies. Yeah, I have not seen any neonatal tracheostomy in my career as yet. So you can do it as an end procedure.
Yes. And second is, some of these patients, they may have bilateral cord palsy, laryngeal webs, subglottic webs.
Right.
So we should be ready in such cases and it is easy, not very difficult.
Okay. So in utero diagnosis and then doing
Prenatally, when placenta is still attached, we can do tracheostomy. Second is, if child has come out, then and we are not able to ventilate, we have seen some subglottic web or large hemangioma. So these are 2-3 conditions for which you have to do tracheostomy: subglottic hemangioma, bilateral subglottic web.
We are happy, sir, you are there.
Actually, tracheostomy is recommended, na? Cricothyroidotomy is not done.
No.
That is not done.
I hate
so the answer is
cricothyroidotomy.
tracheostomy only.
ENT surgeons hate cricothyroidotomy.
Thank you, everyone.
Thank you so much, Dr. Lakshman.
And thank you all the dignitary for such informative discussions. May I now call upon the respected chairperson to kindly facilitate our speaker, Shama. Please come on stage for the floor. May I call upon the chairperson. Professor Nasir Ahmed Bhatt sir, Nisar sir, please to facilitate our chairperson. Thank you very much all. Before we start another session, just a little announcement. We have found some keys from the hall. If anyone have lost them, you can collect it from the backstage. Moving to our next panel discussions, may I first call upon the moderator for the session. So next. May I call upon Dr. Darwin Kaushal sir. Sir is additional professor in Department of ENT, AIIMS Jammu. So thank you.
So good afternoon everyone. I am Dr. Darwin. I am additional professor at AIIMS Jammu. I am ENT faculty. So this is a very unique panel about challenges in management of tracheobronchial foreign bodies which require multidisciplinary approach. And in fact, your first line of contact has to be very, very solid. So may I request our esteemed panelists. First panelist is Dr. Sunaina Gupta, Department of Anesthesia, AIIMS Jammu. Second is Dr. Kamal Kishore. Sir is professor at GMCH Jammu Medical College. Third is Dr. Smriti Gupta, our pediatrician at AIIMS Jammu. And fourth panelist is Dr. Salim Nazki, our pediatric surgeon at Jammu. So we have been allotted 30 minutes. So I'll do my best to stick to these 30 minutes only. So I request panelists also to be very crisp and come out with golden words. So coming to tracheobronchial foreign bodies. Mic hai hamare paas? Yes. So tracheobronchial foreign bodies, this is one of a common life-threatening emergencies, and this is one of a common, in fact we can say household accident also. So this is leading cause of mortality among pediatric population, and there is a need for urgent removal of this foreign body. And out of 100 candidates we have 15% mortality and morbidity also. So lot many complications we can see, and not these complications we see when patient has presented to hospital. So there are some emergencies, those who have not presented even to hospital and have died in remote areas which have been neglected. So yes, there is a huge number. So coming on to tracheobronchial foreign bodies, let us start with our pediatrician, because our pediatrician is first line of contact with all these patients, and in my life almost all patients have been received from Department of Pediatrics. So what is a common age group, Dr. Smriti, which you encounter?
Thank you, sir, for the question. The commonest age group is usually up to the toddler age group.
Mic, please.
वरुण जा जल्दी तुझे इतने बैठी क्या खाए यार
माइक और दे दीजिए, सबको दे दीजिए माइक,
Yes,
प्लीज.
sir.
Yes, please.
The commonest age group is between the 1 to 3 years of the age, and that too among the toddler age group. Infancy is the most common age group where we commonly find the foreign body aspiration. So the reasons for this age group being the commonest is because of the inquisitive nature of the children. They tend to put everything in their mouth. Mouthing has developed at that time. Secondly, also the swallowing reflex is immature, so they tend to aspirate rather than swallow. And thirdly, the protective reflexes, they are also not very much mature. They are still developing, so they tend to aspirate these foreign bodies.
Right. So, Dr. Kamal Kishore sir, what foreign bodies you commonly encounter in your day-to-day practice, and do you have any list of such foreign bodies by which you have a real danger that this is a very dangerous foreign body?
Sir, most of the foreign body nowadays, especially in this season, is peanuts and dry fruits. Because this season, most of the people are using this peanuts.
Right. So you mean to say organic foreign bodies are very dangerous because we have few MBBS students also. Organic foreign bodies and cell batteries are very, very dangerous. So you should be very careful. You agree, sir? Dr. Salim? Any notorious experience you have?
Yeah, notorious experience would be like hair clips. Mothers have the clip.
Hair clips, yes. Yes.
Button battery is very dangerous, especially as a surgeon. I think the rigid flutters, tracheobronchial foreign bodies, the ENT people deal with it. But when it comes to a surgeon, foreign body like button batteries,
yes,
we encounter them because it has already done a damage where you need a
right,
to open it.
Right. So you can see this video, they have tendency to put everything in their mouth. They don't have very good swallowing reflex. So they don't have even molars also at times. So these are few reasons through which this age group is very notorious. And remember, it is not only 1 to 3, but in fact, we have history and we have received so many patients, those who are less than 1 year, when their brother or sister has tried to feed that baby, and you have delayed presentation of all these foreign bodies. So don't ignore this age group. Now, coming to presentation. So Dr. Smriti, how do these patients present to you?
So the presentation is usually very varied.
Yeah.
Sometimes when they immediately take the foreign body, there is history of immediate choking or coughing. Many a times, many parents, they forgot such episodes because that foreign body got further advanced and
right,
gets lodged in the segmental bronchus. So that episode is usually forgotten, and later on the child presents with some recurrent cough, recurrent pneumonias, that too usually in the particular lobe or particular segment, and or the unilateral wheezing. And so these two are the common presentations.
Yes. So Dr. Kamal Kishore sir, any unique presentation you have received of these patients?
Sir, if the symptoms are very unique, especially unilateral, we saw child present with unilateral collapse or midline shift, we always suspect a foreign body.
Yes. So we are talking about clinical features. So let me tell you, any history of acute choking or coughing episode, or when parents presents to you with witness choking, or any patient presenting to you with permanent cough and pediatrician has ruled out any other cause also. So this is a series of 17 patients which we have received at AIMS Jodhpur, where this was delayed presentation, and you can see patient has presented to us with dry cough, breathing difficulty, even fever, features of sepsis, noisy breathing, witness choking and lethargy, by which these patients have presented to us. And let me tell you, any absent of choking event does not mean that patient does not have any foreign body. So it may be a risk factor for delayed diagnosis. Now coming on to, yes ma'am. Yes, very common foreign body ma'am.
Yeah. That patient used to whistle while inspiring.
Right.
That was a different
Yes, yes.
So with every inspiration there was a CT,
So madam has given classical example of that whistle. Yes, जैसे वो inspirate करेगा and suddenly this whistle goes inside. Yes. So coming on to physical examination. Yeah, Dr. Smriti, again this patient is with you at present. I am able to make that 3D picture.
So physical examination usually has a unilateral findings.
Yes.
So most commonly the foreign bodies, they tend to go towards the right bronchus.
Right.
Many
Yes,
We
yes.
usually get the unilateral reduced breath sounds. They could be unilateral V's also. And sometimes if the child is having recurrent pneumonias in that child, we may get bronchial breath sounds secondary to the pneumonia.
Yes, yes, right. So I think two surgeons, how do these patients present? How do you receive, Dr. Salim?
What
Because
I would say that there's like acute and chronic. I would differentiate it in
yes,
acute will be like, ma'am, our research said that with acute conditions like wheeze, stridor, then difficulty in breathing. But there are many patients, like the foreign body has been there for months. We have seen who have the granulation which causes the problem rather than a foreign body there. So we should not ignore the patients who are there with the chronic foreign bodies who have a recurrent pneumonias or any other symptoms. So just keep in mind both acute and chronic foreign bodies.
yes. So granulation, Dr. Salim has said about granulations, which we will be talking about granulation in bronchoscopic findings later on. But on physical examination, many times this fiber optic bronchoscopy can be a stimulus also for the patient.
Yeah, there was one patient,
Yes,
there was
ma'am.
one patient who had this pen, cap of the pen,
Yes.
which was open at both ends. So that got and lodged inside the right bronchus. And since it was open at both the ends, so he was able to, the respiration was okay. But then he developed a patch on the right side. And then decortication had to be done on that patient. It was such a long time because airway was patent,
So these patients, they have increased respiratory rate, inability to speak at times, limited chest expansion, impaired percussion note, and obviously decreased breath sounds, and unilateral wheezing, even bilateral wheezing also. So this is our experience which we have published, that is about delayed presentation of all these foreign bodies. So whenever you get time, you can read this publication. Now coming on to investigation. So again, first line of contact for these investigation many times is a pediatrician. Dr. Smriti, what is your take on chest X-ray or X-ray soft tissue neck AP lateral? Is it a first investigation for you, or you directly go for CT scan?
So many times these children presented, they have a delayed presentation. So they present with recurrent pneumonia. So at that time we usually tend to do chest X-ray,
Right.
which usually shows the right-sided hyperinflation, unilateral hyperinflation or collapse.
Yes.
Definitely chest X-ray would be done. But if there is a significant or the documented history of the choking episode, then we can also directly go for the bronchoscopy.
Yes. So X-ray is a sort of immediate investigation you can do within 5 minutes, and it will give you immediate idea that with what disease patient is suffering from. What about CT scan, Dr. Salim?
I think 90% of them are diagnosed on X-ray. I've seen
On chest X-ray?
Yeah, just X-ray.
Or X-ray soft tissue neck?
Definitely. So I've seen like 5 to 10%.
Dr. Kamal sir, you agree with Dr. Salim that 90% of a time this X-ray is diagnostic?
Sir, it's not necessary, but most of the time in our setup, if the clinical finding and history is very particular and the clinical finding is suggestive of foreign body, even X-ray test, we can go for diagnostic bronchoscopy. There is no harm because diagnostic bronchoscopy with expert anesthetist and expert ENT surgeon is almost safe. So same, I think need for the CT scan is arising only when the patient is very particular कि शायद diagnosis पहले होना चाहिए, confirm होनी चाहिए, foreign body है कि नहीं है, जहाँ फिर where the whole history is doubtful, we can go for the bronchoscopy.
Right. Dr. Smriti, are you comfortable surgeon doing fiber optic bronchoscopy or laryngoscopy in front of you, or do you have any?
So usually the bronchoscopies they should be done by a pediatric pulmonologist because there are because of the already in the previous lecture we have discussed about the pediatric airway. So we should be very particular about managing the pediatric airway, their pediatric
Yes.
anesthesia, so that these children would not land into the complications, especially the bronchospasm.
So many of our pediatric surgeons here and ENT surgeons will be disagreeing with you that this has to be done with pulmonologists, even anesthetists also at times. So I think important message is that chest X-ray is an immediate investigation which gives you results. CT scan is a very good roadmap for you. And yes, fiber optic bronchoscopy or any laryngoscopy in such a child is a very, very potent stimulus for bronchospasm, and many complications can occur even in OPD itself. So it has to be done with greater respect. Now coming to chest X-ray or X-ray soft tissue neck and lateral view, what finding exactly you get, because many residents and MBBS students are also sitting here. So just to benefit them, what findings you get on chest X-ray?
Sir, most of the time we will see either collapsed lung or hyperinflated lung, or there be a midline shift
yes,
to the collapsed side, or if a hyperinflated to the opposite side. So these are the findings. If the foreign body is radiopaque, foreign body can be seen in the X-rays.
Right. Dr. Smriti, any additional findings?
Usually the same findings, only that the chest X-ray should be done both in the inspiration and expiration. You will get the persistent hyperinflation in the expiration.
Right. So unilateral over distension, segmental atelectasis, or sometimes even nature of a foreign body can also be appreciated. Like you can see here, some coin is there, or some battery is there, when you are able to see hello sign or ring sign, and you can also make it that this is nothing but charge battery due to that hello sign or ring sign. So yes, you can at times, many times you are able to make what exactly pathology is there, right? Now coming to CT scan. So I think for many surgeons this is a roadmap. Kamal sir, what is your take about CT scan? You want exactly this HRCT or you want some modification?
Sir, this is basically we are not advising routinely. Every patient before a bronchoscopy, the patient has to go for this virtual bronchoscopy or multi-slice this HRCT. But if there is any doubt or if there is doubtful history hai, so we can go for that. Otherwise, if we do it in our setup, so it's a good thing. It will most of our time localize the foreign body where exactly the foreign body is present.
Right.
And
Dr. Salim, what is your take?
Yes,
yes. Yes, sir, please.
Sometimes the nature of the foreign body is also simultaneously other pathology like collapse or pneumonitis may also be simultaneously seen on that HRCT.
Dr. Salim, your take?
I'll give you a small example. A few weeks back, we had a child with a pediatric in a PICU. So this child had a hyperinflated lung. He was there for like 2 weeks. So they were suspecting a foreign body. So the role of CT we are discussing.
Yes, yes.
So we got a CT done. So they were not sure if it's a foreign body or not. So it came out to be a CCAM rather than a foreign body. So it can help you in a differential diagnosis rather getting to the exact diagnosis. What I believe.
Yeah. So just for the benefit of audience, whenever you have to order this CT scan, always order HRCT and go for 3D reconstruction. This is also known as virtual bronchoscopy. So this is nothing but 3D visualization, and this is obtained through a helical CT scanner. It gives you very good roadmap, and it helps for pre-operative planning also. Remember, this is an era of medico-legal implication. If time permits, don't hesitate to do any investigation which is really needed, and particularly when you are challengeable in court of law. But if time permits, so life of a patient is most important for you.
So I would like to add one point.
Yes, yes.
That CT is usually not required in every case because CT, one thing is very high radiation, so we do not want to expose children to such high radiation. But definitely, if you have somewhat doubt and you do not have the facility of flexible bronchoscopy, then you can go in those centers. You can go for CT scan for the exact diagnosis. But many a times, CT can also miss the foreign body, especially in cases of organic foreign bodies. So
this is a pediatrician view, but many times what surgeons have a problem when your chest radiography is not conclusive of what is a type of foreign body, what is exactly location, or when you have high suspicion and findings are not clear, that makes an indication to do CT scan. It is not needed in all cases, but these are two important scenarios where you need CT scan. So this is a very good publication published in International Journal of Pediatric Otolaryngology, which have seen almost 2500 patients, and you can see that radiological findings which were important is emphysema, atelectasis, pneumonia and sepsis, bilateral distension, even subcutaneous emphysema also, and many times radiopaque foreign bodies, pleural effusion and destroyed lung. Now coming to role of anesthesia, very important. So remember, if you want to become a good pediatric surgeon, then Department of Pediatrics and Anesthesia people should be very good friend of yours. And one of my teacher always used to tell that sometimes to make good friends even you can also plan to marry them. So Sunana ma'am, what is exactly goal and consideration, important consideration when you deal with such small babies, pediatric patients?
Okay, the first is like, as you said, pediatric patient. Dr. Raksha has already elaborated.
Yes,
why,
madam has
yes,
made our job
yes,
very easy.
he elaborated why the pediatric patients are different. And of course, we suspect anticipated difficult intubation, difficult airway. So because of the various factors like the head is large, the tongue is large, relatively small mouth opening, and then anterior larynx. So already they are like a high risk group for anesthesia. And at the same time, like the main concentration is the shared airway. So
Yes.
PT and anesthesia people are there sharing the airway.
Yes.
So that is also one of the issue, that is a consideration. And these patients, it is difficult to, there might be difficulty in oxygenation and ventilation.
Yes.
So these are the main important anesthetic consideration that are to be taken. And pediatric airway, yes, it is difficult, difficult.
Absolutely right. So madam has said important question is about adequate oxygenation. Sometimes people struggle to get even IV access also when patient is very uncooperative. Then what about reflexes of these patients? Then aspiration prevention, and no doubt about it that we need very good monitoring also. And many times these babies, they come, patient has just taken meal or patient has just taken milk. So risk pertaining to pediatric anesthesia, risk of hypoxia, this is very important, because if you see allowable time which anesthesia people they are going to give to us is,
it
again,
is just 1 to 2 minutes. It depends
yes.
on case specific, but still it is 1 to 2 minutes if it is intermittent apnea technique.
Yes. So next is anesthetist challenge. So we have three important aspects here: intubation, ventilation, and ventilation by bronchoscope. So Dr. Salim, you are comfortable with intubation or no intubation?
Intubation in terms of you mean to stabilize the child, or you mean in terms of taking a child to the
We have tracheobronchial foreign body is in primary bronchus. You want to intubate or not?
No, I would not be happy to intubate the child. I would rather rush to OT.
Right, absolutely right. So, ma'am, what are these few cases? What is your challenge about intubation and even ventilation also? And what are those cases where you want to go for jet ventilation?
Yes, it is like before intubation also we have certain challenges, like as you said, the IV line.
Yes.
And second thing is we would like to like mask induce the child. If we have an IV line, it's okay, then we can go for both IV and inhalation injection. But one thing is very important, that we don't have to give positive pressure ventilation during the induction also, because
Yes.
that will push the foreign body more distance.
Very important for undergraduates
Yes.
and residents also. So no positive pressure ventilation.
Yes.
जितना permissible हो उतना ही. Yes, ma'am.
Yes, that is one thing. And second, regarding pre-medication, we will not like to give any anxiolytic to these babies, because
Yes.
it can cause respiratory depression. And we will like to give, because secretions is an issue, and we would like to give anti-sialope like glycopyrrolate. And one more thing is, we suspect that the inflammatory changes might have occurred because of the foreign body, and because of the repeated handling of the airway, there can be, we can give dexamethasone pre-operatively. So these are two things, glycopyrrolate and dexamethasone we can give, and we will avoid this anxiolytic. Now during induction, as I said, we would like to be induce, it should be a very smooth induction, and we would like to do it with sevoflurane and propofol both. And at the same time, we will not use nitrous oxide, because nitrous oxide can further cause, like if it is a barrow, because it is a closed obstruction, so it can cause barotrauma and pneumothorax. So nitrous oxide is avoided.
What about jet ventilation, ma'am?
I'm coming to the techniques.
Yes, please.
So there are different 3 or 4 techniques we can use. Either we can ventilate with the help of the sidling of the ventilating bronchoscope.
Yeah, so that is very important again for residents, that ventilation via bronchoscope. So surgeon is also comfortable, anesthesia people are also comfortable. So you can see third picture, ventilation through bronchoscope is Very important.
Yes.
Yes.
Then we have a manual jet ventilator as you have shown in the picture. So this can be attached with a specialized bronchoscope also, or we can give high frequency jet ventilation with the help of catheter also. So the difference between the two, this jet ventilation and normal ventilation is, in this tidal volume is very less, but the frequency is increased. Like in manual jet ventilation, we can go up to 40 to 50 per minute. And in cases of like high frequency jet ventilation, it goes up to 200 to 550 per minute.
Okay.
And what is the mechanism? Basically, when this this jet of air at high pressure and high frequency, when it entraps the air along with it. So that is how inspiration occurs, and the passive expiration is passive in this. So one thing it should be very clear that whenever we are using jet ventilation, there should be no obstruction. Otherwise, it can cause panic.
Right. So good pre-oxygenation, preferably no intubation in case of tracheobronchial foreign bodies, not for esophageal foreign bodies, for tracheobronchial foreign bodies, and good coordination between the teams is very, very important here. Now coming to surgical options.
Just one thing I would like to say is
yes, ma'am.
that good, scope is also very important. Good instruments is very important, because
We are talking about instruments. Next slide is about instruments. Yes. So, Dr. Salim, what is your take about surgical options? Which technique you prefer? You prefer rigid or flexible?
Bronchoscopy always.
Rigid?
Yes.
Yes. So, any case for flexible bronchoscopy in pediatric population?
I have done many with the rigid bronchoscope, never used it flexible.
Yes, there is no doubt about it that rigid bronchoscopy in pediatric population is gold standard. Yes. What about fiber optic bronchoscopy, Kamal sir? Have you tried in age group of like 13 to 16 or 18? Huh?
Diagnostic role.
Diagnostic.
Because we always prefer rigid bronchoscopy because of the larger size, larger lumen, and we pick up the foreign body directly.
Yes. So there is no doubt about it. Rigid bronchoscopy is very, very good, and fiber optic bronchoscopy is basically for adults also. Recently we have referred one patient to our GI surgeon, and I was very happy that they have taken out this fish bone with flexible bronchoscopy. So yes, it is very good. Now coming to preparedness, because this is of key importance. Whenever these foreign body kits they come to emergency, there is a sort of chaos among nursing officers, staff, HA, SA, surgeon also. So preparedness is very important. We have instruments from different companies. Every company is good, to be very frank. Castos is good, Wolf is good, other companies are good. But have you encountered any difficulties when you have a single company instruments, Kamal sir?
No, sir.
Because problem is why I have asked this question, because many residents they are going to start some private practice outside, and suppose they have taken instruments from car stores or particularly from any XYZ company, do they encounter some problem? Because probably in your center you must be having instrument from all three companies.
Before going to the into the bronchoscopy, we
Yes.
always check for the trolley, it is properly planned or not. And we see the connectivity, जैसे light source connectivity and connectivity with the anesthesia also, it is feasible or not. And simultaneously, we check the instrument that their pickup or their working is proper or not. So all these things can be checked before we jumping into the bronchoscopy.
Right.
Working of the instrument, attachment, and all the working, and we will check.
So rightly said, Kamal sir has said instrument compatibility is very, very important, and this problem we have encountered so many times that we are using instrument of a particular company. Optical forceps is not going through bronchoscope, or bronchoscope is not compatible with optical forceps. And if patient is under anesthesia and then you are checking instrument compatibility, then it is going to be problematic for patient. And yes, your total surgical time should be, I mean to say, more than 90% of your surgical time should be you should be prepared in such a way that you should be spending your all surgical time in instrument, checking instrument compatibility. You should be ready when this patient is under effect of anesthesia, and it hardly takes 4 to 5 minutes to take out that foreign body. So that is very important. So you have to do a lot of homework before subjecting this patient to operation theatre, and your trolley should be like this. Now coming to rigid bronchoscopy, there is no doubt about it, it is treatment of choice and it has got success rate over 90%. So for residents, this picture is important. This is how we have, through which telescope goes. You can see side pot through which light is coming, and third pot is ventilation tubing. And this is optical forceps through which we can directly see. So this slide is for residents. Now coming to complications. So Dr. Salim, what complications you have seen or have heard from different surgeons in your practice?
So again, it's the same question, like acute and chronic. So
yes.
Acutely, like distressed patient, then the respiratory problems.
Yes.
The patient directly going to ICUs. Even the worst come worst, there are many deaths we have also seen. It's not that people are not dying with the foreign bodies.
Sunana ma'am.
So the complications like intraoperative complication, pneumothorax, inability to oxygenate and ventilate, so hypoxia, desaturation, it can lead to cardiac arrest also.
Yes.
And one more complication, barotrauma.
Right, ma'am.
Another is when a surgeon is trying to remove the foreign body, sometimes what happens, it gets stuck in the trachea.
Yes.
So I think that is a very emergency situation.
So that is also important, that primary bronchus foreign body becomes tracheal foreign body. Right, so that is very
complete
important.
obstruction.
Yes.
Perforations many times.
Perforations, yes. We are going to talk about next clinical scenarios also. So I think I am left with last 10 minutes. So
many times, when the bronchial foreign body becomes a tracheal,
yes,
you have to push it to the
right, ma'am,
to make the airway patent. Otherwise,
right,
you can lose the patient.
Right, ma'am.
About the thing I was talking about, forceps are very important. That the grip of the forceps should be checked, because many times you can see the foreign body, but the forceps is not good and accurate to pick up to pick it up.
So instrument have to be very good.
It will keep on losing the
yes.
foreign body, and again it has to be.
And many times we struggle in government institutes.
Yeah, especially I belong to that category. Yes. There was one instance of metallic ball. And I don't know how many times
we have in our clinical scenario about this.
Metallic ball is very dangerous because
yes.
grip ही नहीं बनती है ना.
Yes. So Kamal sir, this is first.
The most important thing is, ma'am said, is a coordination with the anesthetist.
Yes.
What I believe that you should always do a case with the anesthetist you know.
Yes. So right.
You never know, like if ABC is coming to you, so you need a competent anesthetist you are happy with.
You don't have that option in government hospitals.
Before the procedure, I think the anesthetic surgeon should plan what they are doing.
Surgeons should be quick and precise, because anesthetist is a backbone in this case. It's no doubt without anesthetist,
yes,
bronchoscope is not possible. But surgeons should be quick and precise. Quick and precise.
So Kamal sir, first case for you.
अर्जुन की आँख जैसे होंगी वैसे होनी चाहिए.
So first case for you, we have gone through tracheal bifurcation, and just distal to tracheal bifurcation we have received this picture. So you can see one opening, another opening, you are able to make out some secretion is there, but you are not able to see where is the exact opening. So what important precautions you will take here for beginners?
Sir, I have encountered similar case with this case, because
yes.
I have moved a foreign body almost to 1.5 months old.
Yes. So first important thing Dr. Kamal has said, this is delayed presentation. So there is some stenosis here, and you are able to see glimpse of these secretions. So this is delayed presentation. Next, sir.
And I have sucked out that secretion, and with the help of suction, I have just palpated the area.
Very good. So next important thing is suctioning and palpation. Right.
Suction and palpated that area, and on palpation I have seen a gritty sensation in the palpation. So, and then I just localize. I am able to localize the foreign body, and that foreign body were moved, that it came to a stone. That 1.5 month old
right,
stone I have moved, and there are a lot of granulation around that foreign body also. So we can, with rigid endoscope, we can put a adrenaline swab for some time.
So excellent. I think key message is no blind probing. Otherwise, patient is going to get pneumothorax and come out with ICD. So this is very important. Next case goes to Dr. Salim. Salim, sir, bataiye. So this is some cell battery. So what is the key message for residents? What precaution you should take in key battery? Patient is coming at 9 o'clock in the night, and you have gone to your home. Resident has called you.
I will come back, Rashid.
Yes. So come back. come back and remove this foreign body immediately. So that is a key message. It should not be removed in the morning, particularly when it is charged cell battery. Otherwise, it is going to perforate next day. So yes, third scenario. So this is urgency.
So I would like to add something.
Yeah,
This battery.
please.
This battery basically it causes release of electrolyte. And
Yes.
this is electrolysis. So what happens? Necrosis starts occurring around the foreign body. So it can perforate. So we should remove it as soon as.
Okay. So there is no contraindication for anesthesia, madam is telling you, and patient can be taken without PSC clearance. Chalo. I'm just joking, ma'am. Third clinical scenario, Kamal sir, sharp pain inside.
Emergency, so
yes.
Patient can be compromised on that.
Kamal sir, sharp pain. What message for residents? What precaution you should take?
I have moved that sharpen many times, but most of the time I am able to, if I am able to localize the sharp end, so that sharp end is picked up and brought into the bronchoscope. Then we retrieve an instrument along with the bronchoscope.
Right.
It is safest procedure.
Very good, very good. So these sharp foreign bodies, you should be very careful that there should not be any mucosal injury or there should not be any perforation. Preferably, if there is some glass sort of thing which you can rotate in bronchus, you should make an attempt to rotate. But yes, it should not be at a cost of mucosal injury. That is of key importance. Like this pin, you cannot rotate in bronchus, so you should try to grasp that sharp end. So that is very important. If sharp end is upward facing, if it is downward facing, again you can cut it. Now coming to next, organic foreign body. Dr. Salim, any tips for audience?
Just
Organic foreign body.
Just try to get it in one piece.
Yes, right.
That's only one message.
Yeah, so you should have very soft and firm grip. So these two words are in fact opposite to each other, but it should be soft and firm grip and try to take out in a single go, right. Next important scenario, Dr. Sunaina was also talking about marble. So you have taken out marble, you are at lower surface of a true cord and suddenly marble is falling again and again. You are not able to take out. Then Dr. Salim?
So this is the most difficult foreign body I feel.
Yes.
So
Because like ma'am has said, very difficult to grasp it.
Yeah.
Yes.
The thing that has always helped me is the Fogarty's catheter, putting it distally and the balloon.
Excellent. So one, you can use that Fogarty's catheter or even Foley's catheter also at times, which is very easily available in every hospital. Any other option? But problem is you are not able to take out again. Then suppose with Fogarty's also you are not again. Sorry, I am taking like Viva, but yes, please. Yes.
So what we did anti-gravity. We put the head end of the patient downwards and then surgeon grabs and then it came down. So gravity can be used for such things.
Kamal
It
sir,
helped us.
Kamal sir, your tips?
Sir, this is not I have tried, but this is a good tip.
ये अच्छा है हेलो पूरे तो उतर आइएगा कौन है आज जल्दी मेरे को रंजू माइक देना माइक ऑन करिएगा
So yes, madam has rightly said that many times, sometimes foreign bodies they lie in PFS, pyriform fossa, or sometimes you can see very common foreign bodies quine, so which can be easily taken out at times. So yes, so here in this particular scenario, tracheostomy can be life-saving, and sometimes you can pull out this foreign body from tracheostomy itself after putting that Foley's catheter inside, take out at a site of tracheostoma. So yes, ending my slides here. So pearls of wisdom, important thing is what we have learned is very, very good interdepartmental coordination. You should have very good friends. And there are wide range of non-specific clinical symptoms. So high index of suspicion is also important to particularly avoid all those patients with delayed presentation. And complication can definitely be avoided by early diagnosis, rigid bronchoscopy, removal under general anesthesia, and by training your staff. So So this was a patient which I encountered 5 years back. This patient presented to some surgeon with quine in pyriform fossa. Unfortunately, first surgeon went through posterior pharyngeal wall, and you can see this CT scan that there is a rent starting from oropharyngeal region till mediastinum. So that surgeon went through posterior pharyngeal wall musculature and vertebral column and perforated through and through. Then referred to second surgeon for a quine, and that during that attempt that quine become a esophageal foreign body. Second surgeon took that patient and perforated pleura, bilateral pleura. Then patient came out with ICD, and slowly over a period of 10 to 15 days this patient developed mediastinal abscess and was referred to our center. So 3 procedures to this patient, and when patient came in a very morbid condition, you can see this picture is almost at a time of before discharge. So message for you is that sometimes there can be so many complications, and whenever, like in these conferences, purpose of these conferences is I am very thankful to this organizing team to have this important panel, because it is not always by doing complication you learn. You can also learn by upgrading your skills by workshop, conferences, clear? And I don't believe in that dictum that you learn always by doing complications. You can avoid these complications. So finally this patient take out, we have subjected this patient to surgery where this fistula was closed by rotating that muscle flap. ICD was taken out. This is, you can see this is pigtail which was kept inside for that mediastinal abscess, and finally this patient was discharged and decannulated. So thank you very much our esteemed panelists and organizing. I am very thankful to organizing team, Dr. Vijay Kondal, Dr. Lucky Gupta, our team of AIMS Jammu. Thank you very much.
Excuse me, right at present we have one case admitted in Nagar, where an organic foreign body was being removed and it resulted in a tracheoesophageal fistula. It's a wide fistula. We did a gastrostomy to feed the child. He got reflux and pneumonitis, and tomorrow, I think day after, now we are planning a feeding jejunostomy, and then in future, closure of the tracheoesophageal fistula.
So I have a question for anesthetists, so don't mind that we are teaching somewhere, the consultant anesthesia at the PGI. So they used to keep the patient, after taking the foreign body out, they used to say that we should keep the patient intubated for 12 to 40 hours. Is it advisable
after taking out foreign
or
body,
after the foreign body
should be intubated?
Should the patient be kept intubated or should we extubate the patient?
Can I answer this question?
Yeah, that's what.
Yes, Sunana, please.
Yeah, it depends upon like where the foreign body was, what was the type of foreign body. So if we suspect if there is any trauma, or if the foreign body has caused any inflammation, or like the procedure was of longer duration. So in that cases, we can intubate and keep the patient for some time till those things settle. But if it was a short surgery, like short duration of surgery, and we were very like the foreign body was not of a longer duration, so in that case we can.
Just this is case to case variation,
yes,
not
case
always.
to case variation.
Not always necessary.
Not always.
I think you must be talking about. I think you must be talking about that scenario where surgeon has done lot of intervention and anesthetists don't have confidence over surgeon. No, this should not be.
Not necessary. I think this is case to case variation. Patient can be evaluated at the same time.
No, I think we should not be pointing against one anesthetist.
One thing I would like to say is that the lumen of the pediatric airway is very pliable. The mucous membrane, that is very pliable, and the diameter of the lumen is very small. So if you have very small inflammation also, that will cause a very high degree of obstruction. Like अगर आपके पास मतलब 1/4 centimeter भी अगर होगी, that will cause it 16 times of the obstruction will be there. So it will just leave a small chink if there is inflammation of the airway. So that might be the reason.
So very rightly
Just
said.
yes,
Dr. Sanjita, please.
Just an addition. I think it happened during your training in PGI when Ravi had one foreign body, that metallic foreign body. Video is available on YouTube. It put an outside magnet. So moving magnet along the stern, and the foreign body was following the magnet, and it was removed from the tube. It's available on YouTube.
Dr. Sandipta, please.
That's it for me.
Thank you very much. I have one addition and one question. So I'll start with addition. So I believe that prevention is better than cure. So awareness among the parents, especially mothers, is very important. And in an Indian scenario, sadly we don't have much of awareness programs, so that child encounters such situation, what mother. For foreign body removal or management of foreign body, which is an acute emergency, is there any dedicated algorithm which we can apply? See, as Darwin sir said, in some scenarios we should go for CT scan, and in other scenarios CT is not required. So I just wanted to ask if there is any algorithms we can use and put it in our ICU or OT settings for
Dr. Sandipta, very nice suggestion. Actually, मैंने भी अभी सोची ये चीज़. I think this is a very nice suggestion that we should have proper algorithms which should be pasted everywhere. And let me tell you example. मैं अपनी family के example देता हूँ. मतलब एक बार क्या हुआ, मेरी sister के बच्चे के गले में कुछ फंस गया. So she called me immediately, and on video call we demonstrated this Heimlich maneuver.
I think
and my sister was able to remove that foreign body, and child was totally cyanosed.
Right.
So. I think yes, mothers should be taught about these. Yes, ma'am. Yes. In some scenarios, it may complicate also.
Dr. Darwin, I have just one simple question,
Yes.
logistical one, related to what you just said. If someone in Jammu city swallows a foreign body, which hospital should they take their child to immediately?
No. Where you?
Nearest where the facilities are available and trained person is available.
Let them answer first.
On a lighter note,
Sir?
On a lighter note, the place where you have Raksha and Vijay together.
So I would think the nearest hospital, I guess, that should be the best.
It should have a person who can manage the airway. It's no use take nearest hospital where he.
So can we send them to SM?
Yeah.
Kamal sir is here from GMC, sir. Can we send them to your medical college?
Yes.
Yes.
You can send them.
So yes.
Sir, the most important that we should have some programs for the like society about the peanuts and all. The most common thing we encounter is breathing. So there should be something to teach them.
Yes.
Awareness, as Dr. Salim said, is very, very important, especially for the
Your
parents.
points well noted, ma'am. We will definitely do it. There is no doubt about it. Yes.
बच्चा ही होता है. मैंने ये भी देखा कि बच्चा जो है अपनी माँ का ही पोता ऐसे पकड़ कर भागे. तो बच्चे का कोई पता नहीं होता. Everyone is, I think, aware of, but still the child can do all these activities. The child has the habit to put most of our thing in the mouth, but
Sir, at my home, children are not allowed to have peanuts.
Yes.
That's it.
Yes.
We should not have peanuts if we have toddlers at home.
Acha, we are running out. We are running out of time. Thank you very much, and thank you very much, audience, for this excellent participation. Thank you.
Thank you, sir. Thank you, esteemed panelists and delegates, for informative and elaborative discussions. Now, may I call on the stage Professor Dr. Abdul Rashid, sir, Professor and Head GMC Srinagar, to facilitate our chairperson. Call on Sunana ma'am. Dr. Kamal sir. request Dr. Darwin sir to please receive a. Yes. Thank you. Thank you. Moving forward to our next session, that is last session before the lunch. Um, may I first call upon the chairperson of the session, Dr. Prabhu Goyal, sir, to the stage. Sir is additional professor, Department of Pediatric Surgery, AIMS, New Delhi. And also may I call upon Dr. Poonam Sharma, ma'am. Ma'am is associate professor in Department of Pathology, AIMS, Jammu. May I now call upon the speaker of the session, Dr. Manish Pathak, sir. Sir is professor in the Department of Pediatric Surgery at AIMS, Jodhpur.
Dr. Manish is going to connect genome to the pediatric surgeons.
First of all, I would like to thank organizers, especially Dr. Vijay Kandal and the other members of the organizing committee for giving me this opportunity. Dr. Vijay asked me to deliver a talk on genome and the surgeon, and I was wondering that why this talk was given to me, because as such I do not have any core interest in genomics, and it is rather more difficult for me to talk about it when the Prabodh is sitting on the chair, who has done PhD on genomics and has done genomic studies on each and every pediatric surgical diseases. So let me try. Okay. So why exactly are we talking about the genomics? Means it is said that virtually every human element has some genetic basis. And in this era where we are talking about the precision medicine, we as a surgeon also must know about the genomics. This Dr. Craig Venter, who has done a lot of work on Human Genome Project, after completion of the human genome, sequencing of the human genome, he said that this is the outstanding achievement not only of our time, but in terms of human history. Human Genome Project does have the potential to impact on the life of every person on this planet. So based upon this particular statement, we can understand means how important the genomics is and how it is going to change how we are going to treat the patients. Now when we talk about the genome, a genome is the entire complete set of DNA or genetic material in an organism. So when we talk about the human genome has 3 billion base pairs, which is organized into 23 pairs of chromosome, and it is containing all the genes responsible for development, function and reproduction. The genomics is the study of genomes. So Royal College of Surgeons of England Commission on Future of Surgery identified 3 core areas which are going to shape the future of surgery, and one of these was genomics, and others were the robotics and the artificial intelligence. We already are seeing the robotics, artificial intelligence being used in our surgical disciplines. So Human Genome Project, it was started in 1990. It took almost 13 years to make or sequence the whole human genome. And but now with the advent of next generation sequencing and the advancement of technology, means all this genome sequencing which took almost 13 years initially, now we can do it within few days. A role of genomics means, at a surgeon point of view, it can be used for screening of the diseases, for diagnosis, treatment, surveillance, genetic predisposition syndromes, precision medicine. And when we talk about the application of genomics, the core areas where it is being used and rapidly it will be involved in day-to-day practice will be the fetal medicine, oncology, transplant surgery, and pharmacogenomics. I will be talking about each and every aspect of these certain conditions. Now, regarding fetal medicine, the fetal medicine, we know that we did in a pediatric surgery OPD, the mothers come to us and they are having, some screening has been done, either the triple test has been done or ultrasound screening has been done, and certain anomalies have been detected. And now we have to decide that what to do for these conditions where we are having suspicion of some genetic abnormalities. Now, till now, what was available to us was the invasive, diagnostic tests like amniocentesis and chorionic villus sampling. Now, non-invasive testing is also possible. Now, fetal DNA can be extracted and genetic mutations can be identified from the maternal plasma also. So, this non-invasive genomic testing may help us in identifying the patients who are having certain genetic conditions, and then we can decide that in which patients are we going to, give the parental counseling regarding the continuation of pregnancy, or the parents may decide, depending upon the anomalies which we detect, whether to terminate or not. Now, this genetic diagnosis, it can be at the level of pre-implantation level also. Now, in cases where already multiple miscarriages have occurred, or the mother has undergone in vitro fertilization. Now, we are concerned about some genetic abnormalities in the fetus. At that stage, before the implantation phase only, what we can do is that, we can do the embryo selection. We can identify the embryo which is not having those particular genetic mutations which we expect based upon the maternal history and based upon the maternal genomes, and only those embryos can be selected which are not having those deleterious mutations leading to certain anomalies. So this is at the pre-implantation phase, and after post-conception, as we discussed previously, that we can identify the genetic anomalies based upon either doing the genotyping of these patients, or at the level of in the non-invasive way, or doing a chorionic villus sampling or amniocentesis. Gene editing is an important concept. Gene editing, this is nowadays a new term is there, genome surgeons. Now, what do these genome surgeons do? Already we have identified that certain alterations in DNA sequences occur. Now, these alterations in DNA sequence leads to certain conditions. If we can alter these DNA sequences and this can be curable. So this is what a genome surgeon is doing by doing a gene editing. This is an interesting field. Now, let us come to the pediatric oncology. The pediatric oncology is the field where it is being investigated, mostly this genomics. Now, at the level of diagnosis, means there are certain mutations which can help us in diagnosing certain conditions like SMARCB1 if we talk about the pediatric solid tumors. Now, if a patient is having this mutation, we can, think of a patient having a rhabdoid tumor of kidney or liver. So then prognostication. Now, let us take an example of neuroblastoma. The neuroblastoma patients, they can behave differently depending upon the tumor biology. The tumor biology is the king at present now. Means a patient who is having certain tumors its fate has mostly been already been decided because of the tumor biology. Now, taking the example of neuroblastoma, means it can spontaneously mature also, or it can present to you at an advanced stage where all sorts of treatment, multimodality treatment may not be able to cure this patient. And what is going to determine all this? This is the tumor biology. So NMIC amplification is one of those. Now, by identifying the NMIC amplification, we can risk stratify these patients and accordingly determine the prognostication or prognosticate these patients. A risk stratification, again, genomics plays an important role. Now, when we talk about the Wilms tumor, we know that till now, when we used to do the risk stratification of these patients, we were incorporating the tumor weight, the age, the stage of the tumor, and the histology of the tumor. But no, these markers may not be that sensitive ones. Nowadays, we have got other sensitive markers like the genomic makeup of that particular patient. A loss of heterozygosity has been incorporated by the children's oncology group within the risk stratification of Wilms tumor. Now, loss of heterozygosity at 1p and 16q, if it is there in a favorable histology Wilms tumor, the chemotherapy has to be upgraded. Similarly, there are patients in we had very low risk group in Wilms tumor patients. Now, very low risk group was the one in which the age of the patient was less than 2 years and the tumor weight was less than 550 gram with a favorable histology. Now, it was seen that these patients are having very low risk and we can treat these patients by surgery only, not giving chemotherapy. This trial was done by NWTS5 and what they found was that about 85% patients it was successful, but some patients had recurrence, so this study was aborted in between. But then when these patients were followed up, it was found that many of the patients who actually recurred, they were curable. So this trial again was started by COG, but they tried to identify some fine markers which can actually determine that which patients can be managed by surgery only instead of the chemotherapy. So this is 11p methylation. Now, the patients who are having 11p methylation probably are those patients in which even when the tumor weight is less than 550 gram and the age is less than 2 years, favorable histology, these patients will require chemotherapy and you should not do the surgery. You should not keep them in surgery only group. So this risk stratification is also possible because of this genomics, this final risk stratification. Now, when we talk about determining the early response to therapy, liquid biopsy has got significant role. I will talk about that liquid biopsy also. Now, targeted therapy, it has already been discussed by Dr. Shabab in between me, that how the targeted therapy means. If we know that there are certain antigens, tumor specific antigens are there, and we can target these tumor specific antigens, then this can reduce the toxicity of the chemotherapy, currently available chemotherapy, and can also reduce the recurrence. Precision medicine, we already are talking about it, this genomics has significant role. Then regarding parental counseling and genetic predisposition syndrome. Now, genetic predisposition syndrome, there are certain mutations. If they are present, these mutations predispose patients to certain conditions. Now, APC and RET, these are the classical examples. Now, APC mutation, it has got almost 100% expressivity in the form of development of familial adenomatous polyposis. A patient who is having comes to us with polyposis and the family member is checked for the APC mutation, and if it is found, it is because it has got 100% expressivity, it is recommended that these patients should undergo a prophylactic total colectomy. So to prevent, because these patients, 100% of these patients will ultimately, will develop colon carcinomas. Similarly, RET oncogene, if this mutation is there, the prophylactic thyroidectomy is recommended because of the MEN2B, medullary thyroid carcinoma. So this has got a significant role in the management and even determining the prophylactic surgery to prevent the development of carcinoma. Liquid biopsy. Now, in tumors, we know that there are certain tumors which are very small, they are non-accessible for the tumor biopsy. or the tumors are heterogeneous. There are areas of necrosis which are there. If we take the biopsy from the necrotic areas, we may not be able to diagnose the type of tumor it is. So in these cases, the liquid biopsy takes it has got a significant role. So what is there when a tumor is there? It has been found that these tumor cells, they are shedded into the circulation also, and it can be identified in the circulating the circulating tumor cells can be identified either in the urine, blood, CSF, synovial fluid, etc. So this will take care of the tumor inaccessibility also, because the issues of inaccessibility is not there. You can just take the sample from the blood and can diagnose these conditions. Similarly, the heterogeneity also is taken care of. So this is a recent advancement in the form of liquid biopsy, in which instead of needing to do the tumor biopsies, we can monitor these patients by doing a liquid biopsy. How do we identify that the cells which we are taking from the blood is actually tumor cell or not? So there are certain tumor specific mutations. If these tumor specific mutations in the form of copy number variations or translocations or fusion genes are there, then we can identify that this is tumor cell. And if that is there in the circulation, those specific mutations specific to certain tumors can help us in diagnosing those tumors. And if certain mutations which are specific for prognosticating, like NMIC, then it can help us in risk stratifying these patients also. We can also determine the early recurrence of these tumors by doing a liquid biopsy, because repeatedly doing a tumor biopsy is not feasible in most of the times. So if the liquid biopsy facility is there, and if we can detect these tumor cells during the follow-up phase, then early detection of recurrence also can be done. Now, another role of this genomics is in cancer vaccines. If we have identified tumor-specific antigens, and the vaccines can be introduced that act specifically induces the immune response against those tumor cells or tumor-specific antigens, then it will reduce the toxicity also of the chemotherapy and will also help in reducing the recurrence. Another area where genomics has played a significant role, or rather is going to play a significant role, is transplant surgery. We all know that the Achilles heel of transplantation is one is the paucity of donors being available, and the second is the immune rejection. Now, if we can genetically engineer the animals with the specific organs having the antigens profile similar to the index patient, then xenotransplantation of these specific organs can be done. Then we can avoid the giving immunosuppressants also. The side effects of immunosuppressants can be avoided. Hyperacute rejection which can occur because of the immune response being elicited against those antigens also can be prevented. So this is the area, if we are able to extract this aspect of the genomics and can apply it within the transplant surgery, it can be a great boon for the human society. Pharmacogenomics. We all see that during even in managing these patients, the certain patients, even when they give them a lot of analgesia, morphine, tramadol and all, they just do not respond to it. No, even pediatric patients. And there are certain patients, even a small dose, they go into some respiratory depression or all. So what is it that is determining all these things? So this is, we all know that CYP P450 enzymes are the ones who are metabolizing it. Now there are certain drugs which get activated when the metabolism occurs, like codeine. Now codeine active metabolite by the CYP2D6 metabolism. Because of that, the active metabolite gets formed and it acts. Now, there can be patient who is not having this, or who is having a variant of CYP2D6 which is not allowing it to metabolize the codeine. Now when it is not getting metabolized, these patients will have poor response to our drug and standard doses will not act. To the contrary, there can be a patient who is a rapid metabolizer of these drugs. Now these, even a small dose can cause fatal toxicity in these patients. And one recent publication was also there in which a mother who was on tramadol, who was rapid metabolizer, this baby who was breastfeeding the baby died because of the fetal toxicity, because the levels were so high, even with a small dose of tramadol, that baby ultimately died. So, in near future, all the drugs, which drug we are going to give and how much dose is going to give to these patients, that also going to be determined based upon the genomics of these patients. So this is what we talk about, we call pharmacogenomics. Genome editing, we already talked about. The genome surgeons are there, they alter the DNA sequence, and once we know that that particular mutation is in the DNA sequence is causing that particular disease, if we can alter it, then we can prevent these disease or cure these disease. There are ethical aspects also in this. One ethical aspect is that we have identified certain DNA sequences, we try to change it, but we can actually off target, and if the off targeting occurs, then the safety is a concern. Another concern is that if we are applying this genomics and gene editing to the embryo, now how to take the how to take the consent. Now we are taking consents from the parents. What about the embryo? Embryo is not going to give consent. Though this issue is there during the pediatric surgery management, also the parents are giving consent for the pediatrics for the children. But this is more troublesome in a case where we are changing the genomics of these patients. And the second thing is that if we do these alterations in the germline mutations, then those alterations will be passed down through the generations. So there is a lot of ethical concerns whether we should do the germline editing or not. So these, and then another ethical concern is regarding the equity. We all know this is a costly, affair. Everyone cannot afford it. Only the wealthy people are going to afford it. So this will lead to, inequity in the medical treatment of the patients. The challenges of genomics. So we talked about what are the roles, where are we going to apply these genomics, but there are certain challenges. Now, one of the challenges that we are actually identifying the molecular abnormalities. Now, there are many molecular abnormalities. We know that we have compared it with the reference human genome. We know that this molecular abnormality is there, but what is its clinical relevance? If we do not know that, then how are we going to manage that particular patient based upon that molecular abnormality, and how to do the counseling? Then another aspect of this is the secondary findings. Suppose we are doing the genomic analysis for a particular condition because we are suspecting that there is a family history, there may be a particular anomaly possible in this particular patient who is having, more predisposed to that particular condition, and we do this, but we identify certain other anomalies also. Now, whether before doing this study, the parents or the patient should be informed beforehand that there is a possibility that there may be secondary findings, and they should be prepared for it. And after taking a proper consent only, we should go ahead. Then regarding the training, we order the genomic studies, we have got the result, but who is going to interpret? The surgeon has to be trained to interpret this result, and also to decide or to be able to counsel the parents and do the appropriate intervention based upon the results. Then as we discussed, that there are certain mutations which have got 100% expressivity, but there are certain mutations which are not that expressive, or they do not have that much of penetrance. In those, again, if we treat those patients depending upon that mutations, it will lead to over treatment, or unnecessary stress will also give, because we are telling the patient that this particular abnormality is there in their genomic profile, but it may not be of any significance because it may not express ultimately. So this is another ethical concern is there. Then, whether if we have identified certain anomalies in a patient, and that suggests that this patient is at higher risk of developing, suppose, cardiac diseases or diabetes or some other anomalies. Now, should the insurance company should also be told about this? Now, this is again a challenge regarding this. And what about the protection of data? So if this particular abnormality is detected, how are you going to protect this data? Because it should not be available in a public domain. No one would like to, would like that his particular profile is available everywhere. So to conclude, the genomics has potential to redefine the standards of care, the precision medicine as we talked about, the targeted therapies as we talked about. So each treatment ultimately will be tailored to the genomic makeup of the patient. But it is also important to educate and train the surgeons to interpret and intervene accordingly depending upon the result, and there should be proper counseling before doing the genomic studies. Thank you.
Thank you, Dr. Manish. You have covered this vast topic very comprehensively and very nicely. Do you have any questions from the audience? Dr. Shastri, बताइए.
Hello.
I wanted to know about liquid biopsy. Like most of the time, not most of the time, many times liquid biopsy all sorts of element, but the biopsy report is inconclusive. They want more sampling. It is not always possible for us to make the child again and to take the consent, other arrangement for another biopsy possible. So what all are the prerequisites so that we can always set up for at least liquid biopsy
So liquid biopsy is still not in routine clinical practice. It has been studied in certain, cancer conditions in pediatric solid tumors like neuroblastoma and rhabdomyosarcoma. Liquid biopsies also means required high-end instruments, equipments, technology. So, till the cost comes down and till we have got enough evidence that it can be applicable for certain conditions, because, we know that the tumor cells are shed into the circulation, and depending upon the mutations, identifying the particular mutations, we can diagnose those conditions, so we can detect the recurrence. But the detection rate, extraction rate is still not 100%. So this is one of the challenges, that how can we, make it more sensitive. And another concern is the cost and the availability of the technology. It is not available at present at most of centers in India. Yes, it is being studied there also.
Dr. Shastri, I'll add one thing to clarify your doubt. So basically, in liquid biopsy, you are trying to detect the DNA of the lesion which is circulating in the blood. So it can be any condition, any tumor, but when there's something growing in the body, some part of the cells are released into the circulation. If you can detect that DNA, that will help you make a diagnosis. Now, more than making a diagnosis, nowadays liquid biopsy is being utilized to see the response to treatment, number one. Number two, for tumor that have disappeared on radiology. But still, if you find that DNA in the circulating blood, then you know that tumor exists somewhere. Or I'll give you an example. You have a child of germ cell tumor. Treatment is completed. Now the child comes back to you maybe 1 year down the line, and there is elevated AFP. Or beta SCG. So what will you do? You look for the site of the recurrence on radiology. Suppose you don't find anything, liquid biopsy can help you in characterizing the DNA. Any other question from the audience? So if the audience has no questions, I'd like to add a few points here which might be of relevance. Yes, please.
The genetic counseling, before you order any genetic test, you have to send the parents for genetic counseling. You should not order it on your own because of the variability of results and the psychological distress of the positive result. So you should not order it on their own. We have seen patients who are BRCA positive and they became so depressed after their reports came because they hadn't gone a thorough genetic counseling before the test. So a genetic counseling is a must before you order these tests.
Yeah, true.
Well, I would rather say it is desirable because I'm not sure if there are any guidelines in place for this, but your point makes sense that the results can be depressing, the results can be confounding.
Yeah. It's better to prepare them for all the results beforehand.
There's one thing which is very unique and very specific to the congenital malformations that we deal with. One thing is that these malformations, these anatomical malformations which we correct surgically, they come exclusively to us as pediatric surgeons. And that is one of the reasons why the genetic basis has not been studied very deeply till now. Now, these malformations may not always have, they may not always be genetic. A father may say that he's the only child with hypospadias in my extended family, so why do I look into the genes? The thing is that our kids with congenital malformations, the disease may not be genetic, but still it has to be genomic. So what I'm trying to say is that our malformations, they develop at that phase of development when, the entire developmental process is being orchestrated, and this happens at the level of genes. So even if this is the first child in the entire family who has a disorder, but then you will definitely find something in the genes. The only problem is there are so many genomic tests, and each test is looking after a different aspect of genetic problem. It could be a simple single nucleotide deletion or duplication that you can find out through whole exome sequencing. Alternatively, it could be affecting the non-protein coding region, then you need to go genome sequencing. It could be a small or a large copy number variation, so then you need to do a chromosome microarray analysis. So there is no single genetic test which can identify all the disorders, but if you are doing it comprehensively, you will definitely find something. Whilst I was presenting, I noted one more point which I wanted to speak on. So you very rightly pointed out that the surgeons need to understand the genetics. So when I started doing genomics, so I realized that there is a big divide between the clinician and the bioinformatician. So it is like we take the blood sample, you give it to the lab, they'll extract the DNA, they'll prepare a library and do the sequencing. And they will give you a raw file which you understand nothing. So then you are dependent on their bioinformatician that they will give you a report. But their bioinformatician do not understand the disease the way you do. And it is not just the name of the disease that is important. So they say give us a form, you write down this child has mid-penile hypospadias. Actually speaking, when you want to go down to genetics, the simple term mid-penile hypospadia does not mean anything because these genes, they work differently. So what is required is the genotype-phenotype correlation, and as of now, presently, as surgeons, we have never thought about genetics, so there's a big divide between genotype and phenotype. So you mentioned very appropriately that this gap needs to be bridged. We as surgeons or our medical students, now it is time that a little bit of advanced genetics needs to be incorporated in the medical curriculum.
Yes, sir. I totally agree with you, sir. Before we order a test, clinician, they should be aware because the amount of data that will be generated, they should be aware of what to do with that. So they should be very clear before ordering this test that what are the implications of the whatever the huge amount of information that will be generated. Sir, and as a pathologist, it's also a request that we get sufficient amount of material for the diagnostic purposes, so that the reports like you were saying that there was a lack of sufficient data to be reported. So for that, because the issue with the tumor is that majority of the tumor may be necrotic at times. So that we are getting that tissue itself, so we have to subject it to histopathology, IHC, and then for the NGS testing. So the actual amount of tissue that we get in the end for the genomic testing would be quite reduced, and it will be difficult to make a good interpretation out of that.
Yeah, means the problem with the pediatric oncology is that there are many tumors who present similarly And on histopathology also means they are having the similar appearance like small round root cell tumors, and there are so many differential diagnoses. So IHC becomes a very important integral part of it, and even IHC sometimes is not able to give us the answer. So that is why this genomics and all those things, once they come into picture, probably they will be able to treat them better and diagnose and prognosticate them.
Yes, sir. So at least 10 to 20% of the tumor cells should be there in our tissue to subject it to for the genetic testing.
I think your point is well taken, and this is actually more applicable for adult tumors. See, when we have a pediatric tumors, one another big advantage of doing genetic testing in pediatric tumors is, see, you're looking for a mutation or a genetic variation. Now, this can happen two ways. Either it's a variation which the child has inherited from either or both of the parents. The other option is he has acquired this variation during his lifetime. So, a tumor in an individual who is 45 years of age means that he had 45 long years to acquire the mutation. Contrarily, if it is a child who has lymphoma, maybe 1.5 years of age, it's very likely, it's much more likely that this was inherited. So we, even if we don't go for a somatic markers in the tumor, we go for the genomic DNA. We take a blood sample, we extract the DNA from the blood and we do. So we'll find those genetic markers to a large extent. But yes, that 1.5 year is good enough for him to acquire a mutation as well, the probabilities. But that's a very strong point, and they should always be there in the mind.
And more of research, collaborative research between the genetics and the surgeons, so that we get good algorithms for the predictive medicine which is going on these days. So the clinical profile that can be combined with the genomic profile to offer a better prognostic, to give a better prognostic value to the patients as a whole. Yeah. Thank you, sir.
Thank you very much, Dr. Misa, for such an interesting session. And I also would like to thank our esteemed chairperson to preside over this session. Now, may I call upon Tracheobronchial ma'am to kindly present a token of gratitude to our chairperson. Okay. May I call upon Dr. Manish sir first. May I also call upon Lucky ma'am to kindly come on stage. And may alias sir, please. Ma'am. Now, may I first, Lucky ma'am, to kindly present our. Poonam Sharma ma'am. Thank you very much. May I request thank you. This was end of the pre-lunch sessions for the today. We will meet after the lunch.
Everybody please join us for lunch. Lunch is ready.
হিন্দিতে কথা বলছিস কেন আমার সাথে বলতো? বাজে অভ্যাস হয়ে যাচ্ছে নাকি? কি? পলিগ্লট? আচ্ছা কি কি ভাষা বলতে পারিস তুই? বাংলা, হিন্দি আর ইংরেজি নাকি? কায়দা জায়গা পাও না। পলিগ্লট। পলিগ্লট মানে ওয়াইড প্রোফাইল। একটা দেশের মধ্যে মধ্যে
सर यहाँ पे ये भी बंद हो जाएगा, तो ये जो नेक्स्ट सेशन होगा ना, ये साथ वाले रूम में होगा। जो ये सेशन होगा ना सेकंड वाला, ये साथ वाले कॉन्फ्रेंस हॉल में होगा। डॉक्टर साहिल सर, डॉक्टर साहिल सर, डॉक्टर साहिल जी। खादी खादी तो ऊपर आइए जल्दी।